So how about rituximab? That was the other one that I had mentioned, right? That we could use for induction. And I know you guys have heard about rituximab in this conference. I won't get into the nitty-gritty, but again, this is more about sort of the medications and how to monitor for what you should be monitoring for. So it was approved in 1997 for treatment of hematologic malignancies. And then in 2006, it was approved for rheumatoid arthritis. So it's been around a while, which is good, so then we can at least watch what some of the side effects are, right? And then it was approved in 2011 for induction in MPA and GPA, and then for maintenance just in 2018. It is also used in lupus, in cryoglobulinemia, in HSP or Henoch-Schönlein purpura, in IgG4-related disease, so we are using it a lot in multiple disease states. The way that rituximab works is really focused on your B cells. So it binds to a receptor, the CD20 receptor on B cells, and we know that B cells make antibodies. That's some of the stuff we're measuring when we're checking your ANCA antibodies and other antibody blood tests, and it helps sort of inhibit that functioning. So that's one of the mechanisms by which it works. Some of the common reactions with rituximab are itching, nausea, vomiting, dizziness, headaches, fever, shivering, and this is all really during the infusion of the rituximab. You can get a lot of these side effects. To try to prevent them, we'll premedicate with Tylenol, Benadryl. Sometimes we'll give you a small dose, well, not small, 40 milligrams, but an IV push of Solumedrol prior to getting your infusion to try to decrease some of these side effects. So those are more infusion-based reactions. Some of the infusion reactions can be very severe, so you're always going to get them in a monitored setting with infusion nurses who know when to call the doctor to make sure everything's going on and know how to sort of problem shoot if there's something that does happen early on. Usually if you're going to have one of these really severe infusion reactions, it's 80% of the time with the first infusion. So that's at least something. So as you go through and you're getting repeat infusions, you have less likelihood of developing one of those very severe reactions. And usually we premedicate, like I said, and slow the infusion if needed. Some of the concerning side effects, I know patients this is a very severe disease. It's very, very rare, but it's something that comes up a lot and is very concerning to patients, and reasonably so. So progressive multifocal encephalopathy. One of the hard things is one of the viruses that sort of is associated with this is the JC virus. And so I've definitely had patients come up to me and say, hey, can I just get tested for that virus before I get the medication so that way I know that I won't get it. That's unfortunately not the case. 92% of the population is JC virus positive in their sera, and it doesn't mean that 92% of people would get it if they were given rituximab. It just means that you can't check that test beforehand to clear someone from getting it. As of November 2015, there were 9 cases of PML among patients who had received rituximab for RA and 2 for GPA. Again, this is more common in cancer patients who are receiving much higher doses of rituximab. And another thing to note, it wasn't really associated with the number of rituximab doses, so it's not that if you get a ton of doses of rituximab, you're necessarily at much higher risk of getting this scary side effect. And there wasn't like a pattern in terms of, getting the dose and then when you would start getting symptoms. So I don't check for anything beforehand. It's something that we always tell our patients. It is rare, it's scary, but like I said, it's definitely in case report numbers, but it is a risk with the medication. You can get severe skin reactions, and of course infections. So like I said, the rituximab works on B cells, right? And so B cells produce those proteins that help protect you. So you're at increased risk because it's decreasing some of those protective proteins. And that's one of the things that we'll be checking for in your blood as you're on rituximab. So stuff we look for are a hepatitis panel, a TB test before we start the medication. Some of us will monitor some of your B cell counts to see about redosing, and that goes into more specifics with some of the maintenance trials that I can talk about if people have questions specifically on that. We'll be checking your CBC, and then quantitative immunoglobulins. That's a measure of the amount of those protective proteins that are being made because we're trying to shut them down, but not so much, and so we got to keep an eye on those numbers. And then sometimes we'll be checking your ANCA titers if it's with ANCA vasculitis. So it's being increasingly used in ANCA vasculitis because of its better overall safety profile compared to Cytoxan, but of course risks still exist. And we're always trying to use enough medications to control the disease, but as little as possible to avoid the side effects, right? So there was a recent trial, and there have been more trials coming up that are basically saying how little can we use. So there was one that was just comparing 4 weekly doses versus the 2 weekly doses, and it showed similar outcomes at 1 year. So that's one new thing that's kind of being looked at. Can we get you into remission with less rituximab up front? And then another Main-RITS-N2 trial looked at maintenance therapy, basically to say, after we have someone in remission and we're giving it every 6 months, can we start spacing it out? Can we start looking at any blood markers to see if there's a clue that they might be developing or headed towards a flare, and then we can dose it at that time instead of every 6 months? And in some cases, there's evidence for that as well. So we are looking as a community at ways to try to decrease your exposure to these medicines. But it's still a work in progress because, again, this was just approved for maintenance in 2018. So now we're looking at using it, but how can we use as little of it as possible and keep things under control?